just give me a minute, then we
Yeah,
can start.
sure. Sure. Thank you.
Good morning, everyone, and a very warm welcome to all of you. I'm Shazia Shabir, your moderator for today's session. On behalf of Neuroptech, I would like to extend a warm welcome to each one of you. Neuroptech is committed to advancing learning and professional excellence in optometry and vision sciences through high quality academic initiatives such as this. We're very delighted to have you with us today for this important and insightful webinar on the topic of magnification and acuity in low vision. Low vision care is one of the most dynamic and impactful areas of optometry. Understanding how visual acuity, contrast, and magnification interact is fundamental in helping patients regain functional vision and independence. Today's session will focus on these core concepts and their clinical application in low vision practice. To guide us through this important subject, we're privileged to have with us Ms. Likhita K, Executive Optometrist at Dr. Agarwal's Eye Hospital. She completed her Bachelor of Optometry from Centurion University and further strengthened her expertise in low vision rehabilitation through specialized training at Cardiff University, which is internationally recognized for its work in this field. In addition, she is also pursuing her master's in optometry from Sankara College of Optometry, further deepening her academic and clinical understanding of vision science. We're truly fortunate to have her here with us, and we look forward to learning from her expertise. But before we begin, I would like to quickly go over a few important guidelines. Attendees, kindly keep your microphone and camera turned off throughout the session to avoid background disturbances. Please use the chat box for any questions. We'll take them up during the Q&A session. To be eligible for a certificate, you must attend at least 80% of the webinar. A QR code for certificate registration will be shared during the session. So please stay attentive. Your cooperation will help ensure a smooth and professional learning environment for everyone. With that, I now invite Ms. Likhita K to take us through today's session on magnification and acuity in low vision. Ma'am, the virtual stage is all yours.
Thank you so much. Good morning, everyone. So, this is Likitanjali here. I think I no need to do a specifically introduction about me, as she already mentioned. And thank you so much for the Neuroptech team for inviting me to speak a few words on the specific topic on today's webinar. Am I audible clearly to everyone?
Yes, ma'am. Yes, ma'am. You may begin now.
Sure. So, give me a moment.
Okay, okay.
So, is my screen visible to everyone?
Yes, ma'am.
Okay, so the today's topic is about the magnification and equity conversions low vision. So coming to the low vision, as everyone knows, what is low vision? Low vision is a thing which refers to a reduction in visual function, which cannot be corrected fully with any kind of medical treatment, surgeries, or any standard refraction. So according to the WHO, the low vision person refers who has less than 6 by 18 or better than the light perception or or visual field less than 10 degrees from the point of fixation. So yet still it has a residual vision for performing the daily task. So it is important to understand that always low vision is not same as blindness. While the concept of low vision care is a functional vision, it's not just a visual acuity what they see. Even the equity on the pardon So even the patient with a poor visual acuity yet can still perform the various tasks by using any kind of visual aids, magnifications, or any rehabilitation purposes, and or by contrast enhancement. So for this, low vision patients, to achieve their target visual acuity, they need a magnification. So coming to the magnification, what is magnification? In low vision, magnification is expressed as a ratio comparing the size or angle of an object to one another. So, the aim of magnification is to enlarge the retinal size image by increasing the object size and reducing the viewing distance by using any optical devices or any magnifiers, etc. So there are different kind of magnification types. All the methods ultimately gives the same aim, like by increasing the retinal image size. So why is magnification needed? As we discussed, in low vision, the objects appear, but it visible too small. It's not about the clarity of the target object, but it's about the reduced retinal image size. So in these cases, the magnification helps enlarging the retinal image so that the photoreceptors can be used effectively in the low vision patients. As we discussed, there are types of magnification. Each magnification has a different type to achieve the visual acuity, but all these methods aim to increase the retinal image size, which helpful for the patients in the daily activities. So the types of magnifications are relative size magnification, relative distance magnification, angular magnification, and electronic magnifications. Today we are not going to talk about the types and how to prescribe magnification, what are the types of magnifiers, but we are focusing mainly on the distance magnification and neo magnification, which are helpful in LV patients in a daily life basis. And these are the few different type of magnifiers which are useful for distance and near. So coming to the distance magnification. What is distance magnification? So it is used when the patient complains about difficulty in seeing distance objects like recognizing patients, or by if television, or if they're going out, then difficulty in seeing road signs, etc. So the main principle behind the distance magnification is angular magnification, as it's one of the type of magnification. So the formula for distance magnification is always the present visual acuity by the desired visual acuity. Desired is also noted as target visual acuity. So firstly, we need to know there will be a standardized visual acuity in low vision is always 6 by 12. Why it's called as 6 by 12 is a standard visual acuity means it's highly impossible to in a low vision patients to gain a 6/9 or 6/6 vision, even with the help of any low vision aids and all. And 6 by 12 is a basic specific measurable reductions in vision that impacts in the daily life activities. So this is considered as a standard target visual acuity in distance magnification. So, for example, if the patient present visual acuity is 6 by 60, then the target visual acuity will be 6 by 12. So, if we calculate this, then the distance magnification will be 60 divided by 12 is equals to 5. Then, here in this case, the patient requires the 5x distance magnification to achieve the 6 by 12 vision target. And hence 6 by 12 is not always a considerable visual acuity because it may vary from patient to patient. And like okay, if you people have any pen or paper, or else you can use a calci as well. uh, So for example, the another example, if the present visual acuity is 6 by 36, then then the desired VA is 6 by 12, then what is the distance magnification for the specific example? You people can type in message or
We have a lot of answers coming up saying it's 3 times.
okay, perfect. I hope you all understand this distance magnification, how to calculate, and or else if you have any doubts, ask me. That's fine. 3x magnification is the correct. So in this patient, we prescribe the 3x magnification distance device. I hope you people are so far clear about the distance magnification. Now moving to the neo magnification. So what is neo magnification? Neo magnification is the most common requirement in low vision patients. Yet people will face a lot of struggle in their daily life activities. So people most concerned about near acuity. Unlike the distance magnification, we had only one formula, but in near magnification, we don't have a specific formula. It usually calculates using Castan-Biome's rule, EVP, and relative working distance. So near magnification is based on a principle called relative size magnification or linear magnification, you may call. So what is near magnification? It's the enlargement of retinal size image by improving to improve reading and near vision task in LV patients. Near vision tasks like writing, reading, mobile users, or reading prescriptions or any labelings on some tablets, something like that. Coming to the Castan-Biome's rule, which is a very quick estimation method, but this method is not widely used as it doesn't give us a very accurate values as compared to the EVP. We'll discuss it later. So what is Castan-Biome's rule? This method is used in low vision to determine the near addition required for reading. So what is the formula of Castan-Biome's rule? The formula is equals to near add is equals to reciprocal of distance visual acuity. So, for example, distance visual acuity is 6 by 60, 6 by 60. Then the reciprocal of that visual acuity, what will be the what will be the dioptric reading distance, and the dioptric value for this is 10 diopters. That means 60 by 60 is equals to 10D. So in this, we always get to know that dioptric power and working distance are inversely related. So while calculating, if we get the dioptric power, then that will be our working distance as well. So for this patient, if the visual acuity is 6 by 60, then the reciprocal of that is 60 by 6. That means the patient has 10 dioptric device with the corresponding reading distance is 10 centimeters. So for example, the distance visual acuity is 6 by 120. Is my screen visible?
Yes, yes, it's visible.
Okay. So for example, if the distance visual acuity is 6 by 120, then what will be the reciprocal dioptric value and the reading distance for this particular case?
20 diopter is the common answer that I can see right now.
Yeah, okay. Okay. Okay, guys, that's correct. Now going to equivalent viewing power, that's called as EVP, which is widely used in calculating the near magnification. As I mentioned earlier, Castan-Bioem rule does not give us an accurate value all the time. Why it doesn't give value when we used to know is like while calculating Keston-Biome's rule and the method and the EVP method, then you will always have a slight difference compared to the EVP value. So what is EVP? EVP, the equivalent viewing power, is a more functional and accurate method because it's directly relates print size and the working distance. Working distance is the main thing which we use in near magnification calculations. So it's always directly relates print size and working distance. So it is specially used for high plus lenses and microscopes and other magnifiers. So the EVP helps us to understand the total dioptric demand at the to the perfect eye. So EVP represents the total effective dioptric power at the eye required to view a near object at specific working distance. So EVP always calculates the specific working distance to view a near object, uh, which represents the total effective dioptric power which required for a eye. That so the formula for the EVP is NCVA divided by target visual acuity into 100 by working distance. And hence we spoke about 6 by 12 is a standard visual acuity in the distance. Likewise, the target equity for near is also considered as N4. Hence, it's not always appropriate. Patient doesn't need always N4 uh, to achieve. It's always depends upon the patient preferences. So, for example, patient reads N16 at a 25 centimeters. So the working distance here is 25 centimeters. Then if we calculate, if convert into the formula, then EVP is equals to N by 16 divided by N4 into 100 by 25. That means the patient here needs a 16 dioptric device must be provided for the patient. Did you guys understand this? If you have any doubts, let me know. Going to the next example, if a patient treats N18 at a 20 centimeter, then what is EVP? EVP equals to N18 by N4 into 100 by 20. That means 22.5. So here patient require a 22.5 dioptric device to achieve its So another example, if the patient treats N24 at 30 centimeters, then what will be the value for this?
20 is the most common answer right now.
Okay. Okay, fine. So did you people so far understand about distance magnification and the near magnification and how it will be calculated and how to use in a daily basis? Okay, yeah, that's 20. Did you people so far have any doubts in this distance magnification and near magnification? Please let me know.
It's all clear, I guess, from the comments that I can see right now.
Okay, that's fine. So next we are going to the equity conversions. I hope you people do not confuse between the distance, near magnification, and also the equity conversions because it's all going to be a math calculations today. So what are equity conversions? Why do we need the equity conversions? As we have different type of equity charts like Snellen, Logmar, and notation for near and CPD. So we need the equity conversions involves which translates the visual equity across different notations and in different distances. So each and every equity is used for the different purposes. For example, Snellen. Snellen will be mostly used in clinical practice um, because it's easy to use, understand, and it immediately tells patients like how much they are reading compared to the normal vision, at what distance, at what feet they are reading. So that's why we use Snellen in a clinical practice. And coming to Logmar, we use mostly in research and low vision. So low vision is Logmar is a standard and scientifically accurate method of visual equity noting. So, why Logmar is used in mostly low vision research means Logmar has, as you can see, the difference between Snellen and Logmar. Logmar always Logmar has a line changed by zero point 0.1 and each letter is denoted as zero point 0.2. That means so if we can have a specific and a correct value what the patient is going to be reading or what the patient is going to be achieved. So that's why the logmar is mostly used in research and low vision patients. And the end notation is called a neovision. CPD is contrast and spatial resolution. CPD is nothing but, let me show you a pic. So as you can see the right picture, it's like Lee chat or views at E or grading C and these kind of things we call it as CPD charts. So as we all know what is Snellen vision chart, how does it expresses in a visual equity? So it expresses the vision as a ratio of testing distance to the letter size. So it can be used either in two ways. We all know in the 6-meter chart type or a 20 feet distance chart type. That means 60 or 20 by 20, whatever. It depends on the hospital or the clinics where you're working. We use these two kind of charts regularly. So, for example, if the patient sees a 6 meter, what a normal person sees at 60 meters, then that we denote as 6 by 60. And 6 by 6 is always considered as a normal standard vision. So, what is logmar visual equity? Logmar is equals to logarithm of the minimal angle of resolution. It expresses equity on the logarithm. So each line changes by zero point 0.1 logmar and each letter is denoted as zero point 0.2 logmar. That's why it is very most commonly used in low vision and research because it helps us to uh, exactly know the what patient is reading and we can exactly note according to that. Then we'll be having the accurate results. So what is MAR? MAR is a minimum angle of resolution. So it is derived from the MAR, MAR. So the normal eye resolves 1 arc minute. 1 arc minute is a basic thing of the MAR. MAR is equals to angular size. That means in minutes of arc. All equity systems are derived from the MAR. And these are the logmar and Snellen charts you people all know. So how do we convert now Snellen to MAR? We all know how we denote Snellen is it's like 6 by some x mark, either 6 by 6, 6 by 12, or 6 by 60 something. So what is mar? Mar is equal to the Snellen denominator by the numerator. So if example, if the patient visual acuity is 6 by 60, it's a Snellen. Then what is a mar? Mar is reciprocal for that. That means 60 by 6. Sorry, did I mention 0.2 in logmar each letter? It's 0.02. So coming to the Snellen to Mar conversion, Mar equals to 60 by 6. That means here we require 10 arc minute. So in this case, the patient uses 10 arc minute instead of 1 arc minute. 1 arc minute is uh, a normal, like how 6 by 6 we consider as normal vision acuity, like that 1 arc minute is considered as normal. So in this, the patient uses 10 arc minute instead of 1 arc minute. So next example, if the visual acuity is 6 by 24, then mar equals to 24 by 6. It means here patient uses 4 arc minute. And in the next example, if the patient visual is 6 by 6, then mar equals to, yeah, that's 1 arc minute. So while converting Snellen to Mar, always remember the Mar formula is equals to Snellen denominator divided by numerator. Now conversion from Mar to logmar. The logmar formula equals to log 10 into Mar. So, for example, if the patient visual acuity is 6 by 6, then MAR equals to, as we all know, MAR equals to denominator by numerator, then 6 by 6 equals to 1. So, in this formula, log 10, I think if you all have calci, you will be having the specific mode log 10 mode. Then if you calculate like that, log 10 into mar value, here the mar value is 1, so you will be having a logmar value is 0, is 0.0. We consider it as a logmar values. For example, if the patient is 6 by 60, then mar equals to 60 divided by 6. That means it's 10. So log 10 into 10 is equals to 1.0. Here we will denote it as a logmar 1.0. Another example, if the patient visual acuity is 6 by 12, then what is mar and logmar? How we calculate log 10? If you can you open your calci, they will be having a specific log 10 basic formula. So if you use with that, then you will be able to calculate this thing. 2 arc minute is like mar value. Then what will be the log mar value? I got different answers like zero point 0.2 and zero point 0.3 log mar.
করো ভাই।
If you calculate log 10 into 2, then it will be like zero point 0.3 some decimal log mar. Yep, it's zero point 0.3. Okay, so moving to logmar to Snellen. Okay, moving to logmar to Snellen. To convert logmar to Snellen, we must remove the logarithm first. That means we called it as anti-log. So the formula for this is anti-log into 6. For the conversion of logmar to Snellen, we don't have a specific kind of calculations or something. Either if you have an anti-log in the calci, or we'll be having anti-log calculations in a Google, so we can directly convert like that. For example, 0.0 is a logmar value, then anti-log of 0.0 equals to 1. So 6 into 1 is equals to 6. So here 6 is the denominator. Hence Snellen is 6 by 6. It's 6 by 6. I'm talking about the first example. If the logmar value is zero point 0.0, then what is the antilog of zero point 0? It's 1. So if we calculate 6 into 1, it's 6. So whatever we get the value, it's always the denominator of Snellen. The 6 will be constant and we will be getting the denominator value. So in this example, the denominator value is 6. So hence the Snellen is 6 by 6. So for example, the logmar is 1.0. What will be the Snellen for this example? Yeah, it's 6 by 60. So for this formula, we don't have any specific thing. So if you want to remember the entire anti-log calculations, then it's fine, or else you can use Calci or Google to convert this to get to know the anti-log values. So did you guys understand this all conversions from Snellen to Mar, Mar to Logmar, Logmar to Snellen? Perfect. Now coming to annotation. What is annotation? So annotation is nothing that it's based on the near print size and based on the size of the print. As we all see in our daily life, in our daily practice, the near vision test type books and all, which they denote the letter size and the print size, like N4, N6, N12. So in this N5, N6, N12, N6, the N is a topographic point size. It denotes as a topographic point size. So while doing the near vision acuity, We all the important thing is reading distance. The reading distance should be specifically mentioned at what reading distance the patient is comfort or patient is able to achieve their target visual acuity. As here also the MAR is a very important factor to express in terms. So formula for near equals to n by viewing distance, that means the working distance in a centimeter, into 40. This is the formula for this n notation. So for example, if a patient reads n8 at a 40 centimeter, then n then 8 divided by 40 into 40 is equals to MAR. Then MAR equals to 8 arc per minute. Another example, if the patient reads N12 at a 35 centimeter, then what is MAR? Again, there are two different answers, 12 and 13. See, for example, if the patient reads N8 at 40 centimeters, then N value is 8. 8 divided by 40 into 4 equals to 8. Simultaneously, if the patient reads N12 at a 35 centimeter, then 12 divided by 35 into 40 equals to 13, around 13.7. The one who got 12 answer can calculate again. 12 divided by the viewing distance is 35 centimeter into 40. So then you will be having 13 mar. We do have all the centimeter. The viewing distance, the patient reading distance is in a centimeter. Mar is noted as a arc minute. That means 13 arc minute, 8 arc minute. It's not in a centimeter units and all. Next one is CPD. As I already mentioned, what is CPD? It's a kind of Lee chart or tumbling Lee chart specifically used for children, Lee grading and all. That's CPD. So what is CPD? CPD is known as cycles per degree. It measures the spatial resolution of the visual system. So in CPD means it describes how many black and white stripes are there in a cycle. As you can see, the letter E. So it describes how many black-white stripe cycles can resolve in 1 degree of visual angle. That means here one cycle consists of one black plus one white stripe. So if a 10 CPD, how much if a 10 CPD consists. That means 10 black white stripes. For 10 CPD, it consists of 10 black white stripes. CPD is also related to contrast sensitivity, and it's also widely used in research and low vision assessments. So the formula for CPD is equals to testing distance divided by 55 into CPCM. Here, if we get to know the CPD, firstly we need to know what is CPCM. CPCM is nothing but cycles per centimeters. CPCM is converted to CPD for comparing the visual acuity. So formula CPD is equal to testing distance divided by 55 into CPCM. For patient sees 5 CPCM, example, testing distance is equals to 55. Then 55 divided by 55 into 4 is equals to 4 CPD. Then we'll be having the CPD value. For example, if the patient sees 5 CPCM at testing distance 45 centimeters, then what will be the CPD? Oh no, it's not 60. Here, the CPCM, the value is 5 CPCM. So the testing distance is 45 centimeters. That means 45 divided by 55 into 5. Here we already have a CPCM value, it's 5. And the testing distance the patient sees is 45 centimeters. Here the formula itself is testing distance divided by 55 into CPCM. That means in the next example, if the patient sees 5 CPCM at testing distance 45, that means we already had a CPCM value and the testing distance. That means we need to convert as per the formula. 45 divided by 55 into 5. That's 4. Correct. Now, how to convert now we understood how to calculate the CPD value. To calculate the CPD value, we should be having CPCM value and the testing distance value, which we'll have while doing. So now how to convert CPD to Snellen? The formula for CPD to Snellen conversion is 30 divided by CPD into 6. Now we all know how to calculate CPD. For example, in this case, if the CPD is 4, then the 30 divided by 4 into 6 is equals to 45 Snellen denominator. Always remember, whenever we are calculating from any value to the Snellen, we always get the Snellen denominator value, because the numerator, the 6 will be always a constant. So whenever we are trying to calculate to Snellen conversion, then we always get the denominator value. So in this example, if the CPD is equals to 3, then what will be the Snellen denominator? No, I'm coming again. The formula is 30 divided by CPD into 6. It's a formula. So if we have CPD 4, then 30 divided by 4 into 6 equals to 45 Snellen denominator. So coming to the example question, if the CPD equals to 3, then the Snellen denominator will be 60. Yeah. So the Snellen is 6 by 60 in this particular case. I hope you so far understand this all the formulas, calculating part, the equity conversions and all. And finally, I attached the logmar, Mars, Snellen, the metric and empirical values, the decimals for that. So for all of the Snellen conversions in Snellen, I only use the metric like in a meter value, not in a feet or empirical value. It's the same procedure for both the metric and the feet. I mean empirical value. You will be getting the same value if you convert. I hope you people didn't confuse between the equity conversions and the magnifications. If you remember the formulas, then it will be easy to calculate. You won't be able to get confused. If you guys have any doubts in this equity conversions or any magnification rules, either in distance or near, you can ask. Sure, I'll share this PPT with you.
Okay, I think Likhita, the presentation is over, right?
Yeah,
Okay, okay. Thank you so much. It was really very insightful and clinically relevant presentation, and I've never seen students being so much engaged. That was a very new experience for me personally because it is full of mathematical terms, and you explained it so beautifully and nicely. Thank you so much. Thank you. Thanks a lot. And now let's move on to the Q&A session. I think you have taken a lot of doubts in the session itself. So we'll have a little less questions, but still, if anyone wants you to ask any question, please drop it in the chat box and I'll read it out for ma'am to answer.
yeah. Thank you.
You're welcome. I think we have our first question by Dr. Mohammed Wasim. What is the difference between optical and non-optical devices?
See, optical devices are like there are different kind of magnifiers, telescope, like spectacle mounted magnifiers, like how we use them to magnify or focus a specific object. That's what an optical devices does.
Mm-hmm.
So what this non-optical device does, it's like mostly based on the environmental task, like how much the light or a contract they use, like how much uh, the vision must be improved. That's the difference between the optical devices and or non-optical devices,
Okay, okay.
especially in low vision.
Mhm. If anyone else has any question, you can go ahead. Okay, let's take a minute. If they have any question, they'll drop it in the chat box. I think it was really nice of you to ask in between if they have any doubt, and you cleared it up with each topic as you passed on. So I think there are no bundled questions coming our way.
Yeah.
Okay, all right. So on behalf of Neuroptic, I extend our sincere thanks to Ms. Likhita K, for delivering such a valuable and informative session. I would also like to thank our participants for their active presence and enthusiasm today. And okay, we have another question. We have a question. How will GV magnification low visual fields in EL's calculation considering what is the question? I think she's missed a
Like if
word.
if we are giving magnifiers to the specific patients, so mostly we'll be knowing the preferences, like what is the preference for the specific patient, like what they're going to be achieved, like what they're going to be used in a daily life activities, we'll be giving based upon that. It's not like we use all the formulas in our same specific patient to prescribe. So I haven't spoke about the magnifiers, prescribing, and all in the specific thing. I only consider the distance and near magnification, which is not a type of magnification, but it's useful for the distance and near magnification.
Okay, and we have another question by Dr. Mohammed Wasim. Which patients should we recommend optical and non-optical devices to? Is there a category or something?
There won't be any category. See, optical devices are always useful for both distance and magnification. It's like magnifiers. For distance, we have telescopes or any spectacle mounted magnifiers. And for the near, we have many kind of magnifiers. It depends on that.
Mhm. You can get the recording of this session on YouTube. We'll post it in, I think, 12 hours. I think there are no more questions right now, so we should wrap up. Before we wrap up, a quick shout out to the wonderful team behind Neuroptic, our founder Adnan and co-founder Asad for their vision and constant drive to keep learning alive, and our administrator Arman for handling everything behind the scenes so smoothly that it looks effortless. Thank you all for making today's session happen.